Hello, my name is Dr. Melanie Bourgeot. I'm a third-year pathology resident at Emory University, and welcome to my 6th video, where I'll be focusing on adnexal tumors with a so-called Paisley or tadpole pattern. So let's jump right into things with our first case. And as usual, the whole slide imaging for this case can be found in the video description. This is a plaque-like lesion on the upper lip of a 67-year-old male. So the first thing to notice is that this is a rather impressive resection going all the way down to the skeletal muscle, which should give you a clue as to the behavior of this lesion. You can also see right here is likely a site of prior biopsy. Looking closer, you can see that this lesion is composed of nests and cords of basaloid to eosinophilic cells within a sclerotic stroma. Other features to note are these scattered lymphoid aggregates, as well as some calcifications right here. Moving to higher power, you can see that some of these nests contain keratinaceous material, while others contain this pale kind of bubbly material, and some contain both. And just to show you that these nests and cords extend all the way into the skeletal muscle, see right here. Also, there is perineural invasion, although I couldn't find a good example in this particular section, but that is an important feature to note for this lesion. So this is an example of microcystic adnexal carcinoma, a locally aggressive adnexal neoplasm with both follicular and sweat duct differentiation. Microcystic adnexal carcinoma is an uncommon lesion, but most commonly arises on the face, especially the upper lip. Like you saw in the case I just showed, these lesions are very infiltrative and can extend into the subcutis and beyond. Perineural invasion is also common and often extensive. These lesions generally don't metastasize or cause death. However, given how deep infiltrative they tend to be, and that they often occur on the face, there can be difficulty obtaining negative margins, as well as significant morbidity with these resections. Other lesions that enter the differential include syringoma and desmoplastic trichoepithelioma, or DTE. Both also show a predilection for the head and neck, especially the face, and consists of Paisley or tadpole-shaped tubules within a fibrotic to sclerotic stroma. Syringoma only shows ductal differentiation, and desmoplastic trichoepithelioma shows only follicular differentiation. Microcystic adnexal carcinoma shows both follicular and ductal differentiation. However, the sweat ducts are often compressed and may be difficult to appreciate. Also, unlike microcystic adnexal carcinoma, both of these lesions are superficial and localized. However, the distinction between these lesions may be difficult on small biopsies. To complicate things further, desmoplastic trichoepithelioma can also show superficial perineural invasion. However, calling something desmoplastic trichoepithelioma with perineural invasion on biopsy is not something I feel most dermatopathologists would feel comfortable doing, given the clinical consequences of misdiagnosing a microcystic adnexal carcinoma. If you'd like to learn more about this, I've included a link to a paper in the video description. One other differential to consider is morpheaform basal cell carcinoma. Features that would favor a basal cell carcinoma include cytologic atypia, necrosis, and a desmoplastic stroma with mucin and artifactual clefting. In addition, immunohistochemistry for CD20 will stain passenger Merkel cells in microcystic adnexal carcinoma, which are not present in basal cell carcinoma. There has also been a proposed algorithm to differentiate between basal cell carcinoma, desmoplastic trichoepithelioma, and microcystic adnexal carcinoma using a panel of immunohistochemical stains. If you'd like to learn more about that, I've also included a link to that paper in the description. And that's all I have for now. Please like and subscribe and stay tuned for the next video, which will be the final video in this series. If you're looking for more educational pathology content, you can check out my Twitter and Kiko accounts. Thanks for watching!